Good afternoon to everybody. We are from RP Center, Rajendra Prasad Center for Ophthalmic Sciences from Unit 2 with Retina Unit. We will be presenting a common case to you. Our purpose of presenting you is the various diseases, systemic disease in which ocular involvement is there. So my purpose is there are various diseases like diabetes, hypertension, or systemic disease or genetic predisposition in which eye examination is very important. So Dr. Shaka and Dr. Mohan will be presenting and will be discussing this. Over to Dr. Shaka.
Good afternoon, everyone. I'm Dr. Shaka, and I will be discussing a case of Ectopia lentis with retinal detachment in a patient with Marfan syndrome, Marfanoid habitus. So, a 26-year-old male presented with sudden onset diminution of vision in his left eye for past 1 month, which was preceded by a history of fall 10 days back. He had no history of flashes, floaters, or similar event in family members. He had a history of sudden onset pain and diminution of vision in right eye, for which he underwent enucleation 12 years back. There was no history of any systemic illness. However, he had an abnormally tall stature and they gave a similar history in father. So we made a pedigree chart where the father was unevaluated, and as per the history, he is systemically fit right now. On general examination, he had a height of 183 centimeter and a reduced upper limb lower limb ratio of 0.712 and an increased arm span to height ratio of 1.087. On further skeletal system examination, there was no wrist sign or thumb sign. There was no obvious chest deformity or hindfoot deformity. There was a reduced upper segment lower segment ratio and an increased arm height ratio. There was no obvious spinal deformity, reduced elbow extension or facial features. He also had skin striatum. The patient had undergone echo and the aortic root diameter was 3.12 centimeters, which was within normal limit. However, there was a redundant tissue in the mitral valve. There was no history of pneumothorax in the patient. On ocular examination, the patient had a well-fitting prosthesis in the right eye with normal palpable aperture and phonesis. However, the vision in left eye was only hand movement close to face with a pressure of 10 millimeters of mercury. The eyelids and eyeball was normal. On anterior segment examination, as we can see in the slit lamp image, the iris was hypoplastic with a poorly dilating pupil and an ill-sustained pupillary reaction. The lens was subluxated superotemporally, and there was a normal anterior chamber depth with a Schaffer's sign. On fundus examination, a total dermatogenous retinal detachment was noted in the left eye with a superotemporal horseshoe-shaped tear. It is not visible in this picture because of the subluxated lens. There was an inferior bullous component with a PVR changes in one clock hour. A diagnosis of right eye artificial light and a left eye high myopia with subluxated lens with dermatogenous retinal detachment was made with PVR CP1, and the patient was planned for left eye scleral buckling. However, at 2 weeks follow-up, there was a persistence of inferior subretinal fluid, and we made a diagnosis of failed buckling, and the patient was then planned for left eye pars plana lensectomy with vitreoretinal surgery. So this is the surgical video. In this, we can see there 325 gauge pars plana codes were made, and first lensectomy was done. Following lensectomy and core vitrectomy and the peripheral shade vitrectomy was done. In this part of the video, you can see that there are abnormal vitreoretinal degenerations which could have caused the failure of buckling. So this is a lattice in which the vitreous is adhered at the margins, and so this has to be shaped properly. Then vitrectomy around the break was done. So this was the break which may be responsible for the failure of buckling. Following shave vitrectomy, the residual lens matter was removed and fluid exchange was done, and the laser was done for retinopexy. So on post-operative day 1, the visual acuity in the left eye was 1/60 and the fundus was attached under the oil. However, the pressure was 30 millimeters of mercury, for which topical anti-glaucoma drugs with oral acetazolamide was added. So coming to discussion, Marfan syndrome is one of the most common inherited disorders of the connective tissue, and the incidence is 1 in 3,000 to 5,000 individuals. It has an autosomal dominant inheritance, and 90% of the cases are due to FBN1 gene mutation. 10% can be due to TGF beta receptor 1 or TGF beta receptor 2 mutations. The diagnosis is made on the basis of revised Glenn criteria, which includes two categories, one with positive family history and the other with a negative family history. In patients with positive family history, it has to be associated with ectopia lentis or aortic root dilatation or a systemic score of more than 7 points. In patient with negative family history, either ectopia lentis with a FBN1 gene mutation should be present, or aortic root dilatation either associated with ectopia lentis, gene mutation, or systemic score more than 7 should be present. The systemic score consists of 9 skeletal features and other 3 non-skeletal features. So coming to our patient, he had a doubtful family history with ectopia lentis. There was no aortic root dilatation and the patient had a systemic score of only 3. So as per the criteria, the diagnosis of an uncertain Marfan syndrome was made. So ectopia lentis is defined as displacement of lens from its normal position, and it was first reported by Borger in cases with Marfan syndrome. It is present in 30 to 72% of the cases and occurs due to febrile abnormalities in the eye. Patient presents with blurring of vision, fluctuating vision, and monoocular diplopia, and it is usually bilateral and mostly superotemporal. Other features due to the affected zonules can be microspherophakia, lens coloboma, and premature cataracts. Other associations of ectopia lentis could be Wein-Marchesani syndrome, isolated ectopia lentis with craniosynostosis or et pupillae, homocystinuria, Knobloch syndrome, and high myopia. The retinal degenerations are also common features in patients with Marfan syndrome. 18% of eyes with Marfan syndrome have some kind of retinal degenerations. These can include lattice degeneration, atrophic holes, or WWOP areas. The pathogenesis of retinal breaks in these patients could be due to the unstable subluxated or dislocated lenses, which exerts traction on the vitreous base, early vitreous liquefaction and posterior vitreous detachment, and abnormal vitreoretinal adhesions and degenerations. So in this figure, we can see the traction caused by the zonules over the retina. The incidence of retinal detachment in Marfan syndrome is 5 to 25%, which is much more than the normal population. And the predisposing factors include ectopia lentis, aphakia, long axil length, early vitreous liquefaction and posterior vitreous detachment, abnormal peripheral vitreoretinal degenerations, and intraocular surgery. It is bilateral in 30 to 40% cases, 42% cases, and these patients are usually predisposed to giant retinal tears, which is 600 times the normal population. So the significance of these findings, these things are that early referral and screening is important in these patients for the prophylactic treatment of the fellow eye. Other ocular features include myopia, which is the second most common ocular manifestation, glaucoma, which can be due to primary open angle cause or pupillary block or secondary open angle glaucoma, strabismus, enophthalmos, downward slanting palpebral fissures, flat cornea, blue sclera, and hyperplastic iris. So, coming to the conclusion, a multidisciplinary approach and genetic diagnosis is essential in these cases. These patients are at higher risk of vision-threatening conditions as compared to the general population, and ocular screening and timely intervention is essential for these cases. Thank you.
Thank you, Dr. Shaka. It was a nice presentation. So the purpose of presenting this case was an ocular case with some systemic association. So in this patient, although we could not establish the diagnosis of a definite Marfan's, but the patient had a Marfanoid habitus. And that is what we are seeing, like the new criteria which have been given for Marfan syndrome are quite strict. Unless they have the cardiological finding, we are unable to properly label it. Although in this patient now we have asked for genetic markers, which will take time, and if we get the gene positive, we'll definitely say is Marfan's. But somehow we have many patients where or maybe we are getting the patients younger, we are getting them sooner, so the cardiological findings are not there. But the definite ocular findings like lens dislocation is there, retinal findings are there, they do develop retinal detachments. So definitely, if we see a patient of such stature, at least all our residents, we would advise them to consider it a marfanoid patient and work it up according to those lines. And because then it becomes a marfanoid patient, the other systemic evaluations become important. Most importantly, the cardiology evaluation and sometimes an orthopedic evaluation. So, and for the others in your clinics, if you see such patients with marfanoid habitus, as Dr. Shaka just told you, a lot of them have ocular findings, and up to say in some series, 25% can develop retinal detachments, which can be serious. And it's like in this patient, the other eye is already lost. We don't know why, maybe because of a prior retinal detachment. So the patients can become absolutely blind. So those patients do merit a screening. We could send them for an ophthalmic examination where we'll dilate the eyes and have a good look at the retina. If we find these peripheral retinal degenerations, which she showed the photographs of those lattice degeneration and some holes in the peripheral retina, then we do a prophylactic laser. So we do a laser around it, which may prevent a future retinal detachment. And if they have these dislocated lenses, if the dislocation is significant, it is coming into the pupillary margin, then the patients do have visual abnormalities. Even the will be difficult to prescribe them with proper glasses. Then we have to take them up for lens related surgeries like lensectomy. And even because it's basically a connective tissue disorder of all these proteins. So because of that protein abnormality, the zonules of the lens become weak, they dislocate the retina, which is attached at the periphery to the choroid, which we call as the ora serrata. There it is stretched, and there we develop the retinal breaks and even giant retinal tears. The lattice degeneration are also thinning in the retina because of the protein abnormality. So all this is related to basically the protein genetic defect. And sometimes surgery is difficult. Like in this patient, the first surgery which we did was buckling, which is the conventional surgery, which is extraocular, where we place a buckle outside the sclera and try to push the retina back in place. That did not succeed because it was not a simple case of a single break. There were multiple other detachments, so we had to go in for the more advanced microsurgery, microvitreoretinal surgery. Again, the video she had shown. So that is now a very good tool in our surgical armamentarium, where we make very small 25 gauge incisions, and we have one illuminator, and viewing through a magnifying lens and a microscope, we are able to nicely visualize the entire retina, remove the vitreous, see where the breaks are, clearly remove all the adhesions from there, traction from there, drain the fluid under the retina, settle it, and what she showed, those white marks, then laser all around the breaks to form a coagulation there, and the retina, it prevents the retina from lifting back again and settles the retina. So that is what we did in the patient, and we hope that at least in one eye the patient would be able to at least have mobile vision and not be totally blind. So such the take-home message is for you: if you have someone with a marfanoid habitus, please send for an ophthalmic examination, and for us, we have to send for a systemic evaluation. Thank you.
What was the visual outcome?
So we have operated in last month. So patient, we put silicone oil at the end of the surgery. So patient still has oil in the eye. If the retina stays attached, say for 2 months, we will remove the oil. After that, we will say that okay, now all the retina is attached. Now patient is okay. Nothing more to be done, and then we finally tell you the final visual outcome. But at present, also patient has about 3/60 vision, and patient is mobile. The only difficulty is some 5-10% cases may redetach after oil removal. So our final outcome we'll be able to tell only after 4-5 months. Otherwise, we are hoping we'll do well at least in one.
What additional information hoping to find by doing the genetic testing to change this management prognosis of
So one is that
patient would be not
yes.
are they paying for our academic curiosity, or is it something that will make a difference?
So one is that we'll be definite that again it is Marfan's, and maybe then we can have advise him a regular cardiology evaluation in the future also, because right now his aorta is normal, there is no mitral valve problem. But if his genetic abnormality comes out to be positive, then maybe it is our duty that maybe even if he comes to us 5 years down the line, a repeat cardiology evaluation might not be a bad idea, even to get detect that early. But like you said, it's not a very important thing. That's why at day one we have not advised a genetic checkup.
only if the patient can afford. Nowadays it's become a little cheaper also, I think around 8,000-9,000 just to pick up a single gene. It's not very expensive. Right.